All right, we're going to talk about metabolic alterations that we see in critical care now. When we see hyperglycemia in critical illness, this is usually a very bad thing. Now, it's associated with all sorts of pathologies, including decreased immune function. Wound healing is often jeopardized. We see it with vasoconstriction, impaired gastric motility. All of these things make the outcomes for hyperglycemia in critical care much worse. We tend to see these things in the more seriously injured patients. Of course, we see it in burns and trauma and transplant, not the least of which is because many of these things we use steroids with. And as you know, when you have somebody who's on steroids, that by itself can make the blood sugar elevated. But add to that the stress of acute illness and perhaps even having diabetes to begin with. It makes it very challenging to deal with these patients. So the patients who are particularly at risk for hyperglycemia are those with advanced age. Also patients with insulin resistance, which is the major problem that we see in type 2 diabetes, right? Type 1 diabetes is a problem with insulin production because the beta cells don't work. And insulin resistance is really the problem in type 2 diabetes. There are also hormonal responses to stress that increase the amount of blood sugar. Catecholamines stimulate that. Growth hormone and other hormones increase hyperglycemia. There are medications that we use. As I mentioned earlier, the steroids certainly increase it. Immunosuppressants, to a lesser extent, thiazide diuretics, beta blockers, but many different medicines do increase the blood sugar. And then there's comorbidities, diabetes, right? Also obesity, pancreatitis, etc. Let me just tell you quick about these two endocrine emergencies that everybody has heard of already. So DKA is diabetic ketoacidosis. We tend to see this in people who have type 1 diabetes. And in fact, it is often the presenting condition when they first declare their diabetes. HHS, I still try to use the old terminology HHNK, but we have changed that to HHS, hyperglycemic hyperosmolar state. This tends to happen, I should say, in type 2 diabetics, those who produce insulin but are insulin resistant. So the next slide tells us a little bit more about the reason that these things happen, but know that there is a higher mortality rate with HHS than there is with DKA. In DKA, we tend not to see such high levels of blood sugar. It can happen at as low as 350, but typically they're in the, 500 range, sort of in that area. With HHS, we tend to see really significant hyperglycemia, which happens because there is a little bit of insulin that's produced. And the effect that has is that it allows the body to keep functioning because there is some sugar getting into cells, albeit not enough. And so although the organism, the body, continues to function with that little bit of sugar getting into the cells, that allows the blood sugar to continue to climb. As the blood sugar climbs, it forces more water out at the kidneys, which in turn increases the concentration of sugar. And remember, there's still some sugar being metabolized in the cells, so it's keeping the organism alive so that it can further increase the blood sugar and force more fluid out through the kidneys, which increases the blood sugar even more. You see what happens? You see how that works? So we tend to see higher blood sugar levels in HHS than we do in DKA, because in DKA, the blood sugar just keeps going up, ketosis happens, and the organism doesn't survive if that continues, because there's no sugar getting into the cells. Here's a little bit of a more visual representation of the differences. But again, it sort of has at its heart what I just explained to you, that with DKA, there is a metabolic acidosis that happens, which is kind of the rate limiting step, prevents the severe hyperglycemia that we see, 700 and more with HHS than we see in DKA. So what are the causes? Well, oftentimes, as I mentioned, this is the presenting symptom for type 1 diabetes. So somebody has diabetes but doesn't know it until they end up with DKA at some point, and they're in the intensive care unit and we're taking care of them. So this is the presenting symptom of their type 1 diabetes. We also see DKA and HHS when somebody is generally controlled as a diabetic, and then something awful happens. They get a terrible infection, they get sick otherwise with a CVA or an MI, or they have surgery, or they're involved in trauma. Any number of these things throw them over the edge, so to speak, and their body can't handle it, and their diabetes spirals out of control, resulting in DKA or HHS. Stress of any kind, particularly pregnant women with diabetes, endocrine disorders like hyperthyroidism, any of these things can really push patients over the edge. Clinical manifestations are many. With DKA, we have this particular kind of respirations that we see called Kussmaul respirations, and the acetone breath, a very distinctive smell of the breath that goes along with ketone bodies being present. With HHS, they tend to be very dry, very loose skin turgor. Again, their kidneys are getting rid of so much water because of this hyperosmolar state that forces more fluid out at the kidney level. Hypotension results, and the patient gets tachycardic. They just behave in a very dry kind of way. So the electrolyte shift is the big thing that happens when you're hyperglycemic. When your blood sugar is very high, it changes. It makes you hyperosmolar, and these are some of the effects that we see with those changes in osmotic pressure. The diagnostic tests that we use are shown here. So the patient's presentation in DKA, mild DKA, the patient is alert. Even in moderate DKA, they can be alert, but often drowsy. Whereas in severe DKA, they become stuporous. That same thing is true throughout the hyperosmolar hyperglycemic state, or HHS. The anion gap is very useful, and we measure that all the time in patients who have one of these syndromes. HHS, it can vary, but the worsening of the the worse the ketoacidosis gets, the higher the anion gap. Along with that, the lower the pH goes, right? The more acidemic they become. The osmolality varies in DKA depending on the concentration, but in HHS, it's very, very high. It exceeds 320 throughout. Serum bicarb, serum and urine ketones are all measured, and the results are shown here. So how do we manage these things? Well, we have to support breathing, right, and airway. So oftentimes these patients are intubated and mechanically ventilated until we can get their metabolic derangement under control. We have to monitor electrolytes very carefully and replace them aggressively in some cases, monitoring the EKG the whole time. And of course, we have to correct the acidemia with bicarb. Nursing interventions are aimed at monitoring the glucose constantly, titrating insulin drips, replacing the electrolytes, and then monitoring hemodynamics as well. Of course, we use insulin, and the only IV insulin that we use is regular insulin. We do also use the ultra short-acting Humalog and the super long-acting Levmir and Lantus insulins as basal doses. And of course, you remember the types of insulin, the onset of action, the peak effect, and the duration of action for each of these types. If you don't know it, you should memorize it, because this is important stuff for you throughout your nursing career, regardless of whether you're working in a diabetes unit. Everybody's going to be giving insulin. So, what range do we try to keep the blood sugars? Well, we definitely want to keep the blood sugars under 150, regardless of what the reason is, right? If they're in the hospital for any reason, particularly if they have sepsis or any infections, we know that those patients don't do as well when their blood sugars are elevated, so we try and keep the blood sugars under much tighter control. Of course, we don't want it to get so tightly controlled that they become hypoglycemic. So it's a fine balance that we have to walk there. Patients who have DKA or HHS definitely need to be on an insulin drip. And of course, when you're on an insulin drip, in most hospitals, that means a critical care unit so that we can monitor you more carefully. We need frequent sugar checks. There are protocols for insulin drips that are followed. And then there are hypoglycemia protocols that we need to monitor as well. And the insulin drip protocol at one particular facility is shown here. You see for blood sugars less than 50, we're going to hold the infusion and perhaps administer some D50. For blood sugar 75 to 99, we'll hold the infusion. And then when it's above that, we have units per hour shown in the middle column, and the right column is the bolus that we use at the beginning of that hour to increase the or to decrease the blood sugar. Now, what about hypoglycemia? Well, first of all, I want to explain something very important to you. You don't have hypoglycemia, all right? I hear so many students say, oh, I get hypoglycemic after, whatever time of the day. If I don't eat, I get hypoglycemic. Well, I have news for you. That feeling you get, we have a name for it, and it's called hunger. You're not hypoglycemic. If you're hypoglycemic, one of these things on the right-hand side is causing it, all right? Hypoglycemia is a bad thing. None of these are good. So we often see hypoglycemia. I would say most often we see it due to too much insulin or somebody getting insulin and not eating. So associated with diabetes, right? We can also see hypoglycemia in critical illness, sepsis in particular, renal failure, heart failure, those kind of things. Hormone deficiencies like hypocortisolemia. We see it with epinephrine infusions. Those kind of things, are in sick patients. If you are not in the critical care unit and you have hypoglycemia, God help you, because it's probably something like a non-islet cell tumor or an insulinoma or some other kind of horrible neuroendocrine tumor. These are just bad things. So thankfully, we don't typically have hypoglycemia, right? If you get those feelings of the shakes and, feel terrible and whatever other symptoms you have, it's not hypoglycemia, okay? You're just hungry. Go get something to eat. So let's talk more about hypoglycemia in the ICU. Glucose use that is more than the glucose production is what hypoglycemia is, right? Makes sense. Let's not make it too complicated. So your body uses more glucose than it has available, and that means that your blood sugar goes down. And remember, the job of insulin is to move blood sugar into the cell. That's its job. And if too much of that happens, and there's not enough blood sugar in the bloodstream, then you can have symptoms like mental status change, dizziness, paresthesias, eventually unconsciousness, and seizures. But associated with those things are also tachycardia, palpitations, diaphoresis, all these things that, by the way, are masked by beta blocker, right? So we have to recognize this quickly so that we can intervene and prevent the problem. So what are the causes of hypoglycemia? Well, many of them are listed here. Medications, particularly the insulins, are big ones. Insulins or oral hypoglycemics. Remember, though, that metformin, one of the more common hypoglycemic agents, actually does not cause and cannot cause hypoglycemia itself, right? So metformin simply decreases the absorption of sugar in the gut, decreases the liver production of glucose, and sensitizes the cells to insulin. It does not produce extra insulin production. All right. And as a result of that, it can't make you hypoglycemic. So although we usually hold it in people who are, or I should say, we often hold it in people who are NPO, it's not necessary to do so. You won't become hypoglycemic from metformin. But insulin, the secretagogues, all those other oral anti-diabetic medicines, absolutely, they could make you hypoglycemic. Not metformin, though. Other things that cause hypoglycemia: acute kidney injury, other medicines, alcohol, strenuous exercise, those kind of things can all cause hypoglycemia. Here are some of the symptoms. And remember, many of these symptoms are masked by beta blockers, right? So the fast heartbeat, the dizziness, the sweating, irritability, all those things can be masked by beta blockers. At each hospital that people work at, you'll have different hypoglycemia protocols to follow. This is one in particular where the blood sugar is 50 to 70. We're going to give a certain amount of carbohydrate. Remember that every 50 grams of dextrose, that is an amp of D50, or a bag of D5W, a liter bag of D5W, has about 200 calories in it. So when you give that amp of D50, that's 200 calories that you're giving right into the vein. And, you're going to have that sequela to deal with for the rest of, for the rest of the day, perhaps. So we don't want to necessarily go and give a huge dose of sugar. This is the protocol then if the sugar is less than 50. So hypoglycemia needs to be dealt with right away. It can lead to coma if it's not dealt with. Thankfully, it's pretty easy to deal with it in an emergency. We just give a little sugar IV, and that alleviates the symptoms. So let's talk about some other metabolic issues like adrenal issues. Remember that the adrenal gland, first of all, it has a couple of parts to it, right? It has the cortex, that is the outside, and then it has the medulla, which is the middle part or the inner portion of the gland. The cortex produces cortisol, which is a glucocorticoid. And the cortex also produces the mineralocorticoid. The inside or the medulla of the adrenal glands actually produce the catecholamines. And we're not going to talk about those right now. We're going to talk just about the corticosteroids. So remember that these cortisol and the other glucocorticoids are the typical steroids that we talk about when we're trying to treat inflammation, for instance. They suppress this mediator release of histamines and kinins and the interleukins and the tumor necrosis factor, and all those other things are mediated through this glucocorticoid dose. The mineralocorticoids are really responsible for water and electrolyte balance. And in fact, when we have somebody who has hypotension and chronic hypotension, we often give them a mineralocorticoid to try and manage that and make the kidney hold on to some more sodium and water. Now, what happens when somebody has adrenal insufficiency is that they become sort of Addisonian. And remember, these are the patients who have the bronze-like tan, but also low blood pressure. They're at risk for infection and sepsis and things. So this primary or Addison's disease is an absence or a lack of adrenal corticosteroids. There can be secondary adrenal insufficiency if the pituitary gland fails. So in primary adrenal insufficiency, that's because the adrenal gland is broken and it's not responding to signals from the pituitary gland. In secondary adrenal insufficiency, that's because the pituitary fails to send out ACTH, or the ACTH that it sends out is broken and doesn't get picked up by the adrenal gland. So the different scenarios where we see these problems are shown here. Remember that with secondary, that tends to be seen in head trauma because of damage to the pituitary gland, and also in surgery. Brain surgery, that is. So adrenal insufficiency typically is the muscle weakness, loss of appetite, weight loss, abdominal discomfort, hypotension. Those kind of things are adrenal insufficiency manifestations. As with diabetes or other endocrine problems, any stressful event such as surgery or trauma or what have you can really upset the apple cart and cause symptoms to worsen substantially. When there is absence of cortisol and aldosterone, or what we call Addisonian crisis, that causes vascular collapse, severe hypotension, and is life-threatening. And that needs to be dealt with very quickly. So the way these patients present, if they have a lack of cortisol, is shown at the top, both primary and secondary. And then lack of aldosterone, or the ability to hold on to sodium and water, is shown here at the bottom of the table. So remember that lack of cortisol causes hypoglycemia, confusion, lethargy, tachycardia, sweating, also some hypotension. But the place we really see the hypotension is when aldosterone, also a corticosteroid, this is the mineralocorticoid, is diminished or absent. And that's where we see severe hypovolemia, tachycardia, cool, pale skin, weak, rapid pulse, etc. So what diagnostic tests do we use? Well, here we have to get into those funny endocrine tests, like the ACTH stimulation test. So it's hard for me to explain this. I'm just going to read the slide, and I hope that it resonates with you. We find some synthetic ACTH laying around somewhere, and we inject that into the body. The samples of blood, usually it's blood. I actually haven't seen it done with urine, but I may be mistaken about that. But we take samples and we measure before and after. We measure the cortisol levels before and after the ACTH is administered. If there's a rise in blood and urine cortisol levels after the ACTH injection, that's what we expect. That's a normal response. But if the cortisol level doesn't change, then that is a positive or an abnormal ACTH stimulation test. All right, and that suggests adrenal insufficiency. So to fix this, we give steroids. We give hydrocortisone or Solu-Cortef. We can give dexamethasone or fludrocortisone, depending on what exactly we want to replace. We can give these different medicines. The side effects include heart failure and insomnia. Remember all the things that happen with steroid treatment. Heart failure results because of fluid volume overload. Insomnia because these steroids are stimulants to the CNS. It increases gastric acid secretion, so peptic ulcers are common. You get immunosuppressed, and we also see high blood sugar result. So none of these should be a surprise to you if you know how patients respond to corticosteroids when they're given. Over the long term, these patients develop Cushingoid features, right? The buffalo hump and the purple striae in the skin, the skinny arms and the big belly and all that stuff. ADH is regulated in the pituitary and the hypothalamus, and an excess of a decrease in ADH causes diabetes insipidus, right? This is an excessive amount of very dilute urine that gets put out when there's not enough ADH circulating to minimize those effects at the kidney. So urine just falls out. If you've ever seen somebody with DI, they are peeing constantly. It's a very pale urine and has a very, very low specific gravity because it's not concentrated. The opposite then is when there's too much ADH. If there's a tumor of some sort, we get this syndrome of inappropriate antidiuretic hormone. Too much ADH circulating makes you hold on to fluid. You don't pee as much, and that's just as bad, although for opposite reasons, right? So we tend to see DI in head trauma or head surgery. Brain surgery, that is. We see it in infections, and also it produces we see it in water intoxication. SIADH we can also see in trauma and surgery, etc. There's also a certain number of these patients who have pneumonias or lung tumors who get SIADH. And I don't fully understand that mechanism, but I've seen it a couple of times and I'll never forget it. And I look for it all the time whenever we have somebody who has those kind of symptoms, lung or head symptoms. I always think of it. It can be medication induced too from ACE inhibitors. Amiodarone, which causes everything, by the way, can also cause SIADH. Although I haven't seen it, I am not surprised that it happens because amio is such a mess to deal with. The ADH disorder presentation looks like this. For DI, it's a hypovolemia, and for SIADH, it's a hypervolemia presentation, right? Because diabetes insipidus, we're getting rid of all this fluid. It just keeps falling out, which makes the sodium level higher because we're getting rid of all that fluid. And in SIADH, we tend to see a increased urine osmolality, but the serum is the opposite. The way we treat it is to fix the cause. So in diabetes insipidus, it's often medication. If we can get rid of the cause, whether it's a medication or a trauma or whatever, get the healing to happen. Sometimes it's just the tincture of time that's required after brain surgery or after trauma in order to resolve the DI or SIADH. Either one of those gets better with the tincture of time.